All right, everybody, we're back into it. Here we go. So now we're going to be talking about tibial stress fractures. I got to turn the tunes down here. Too much fun. All right. So tibial stress fractures. What do we have to get? Number one, this is the most common location for a stress fracture in the entire body. Other areas where you can see stress fractures typically are on the lower extremity, things like the calcaneus. You can see it on the metatarsals as well, quite commonly. What you're looking at here is effectively a repetitive micro trauma that the body does not have time to adapt to. So, tibial stress fracture, most common site of stress fractures, two main types. Posteromedial stress fracture is more common. And an anterior tibial stress fracture can also occur as well, but it doesn't really matter where the location is. The person is in pain from a repetitive excessive load. Incidence. 10 to 15% of athletes will likely get this from overtraining at some point or another. Super common in our peak athletic years, 20 to 50, and slightly greater in females than males. And we'll see why that is here in a second. So number one risk factor, rapid increase intensity where you have not had time to train and adapt the body into that space. Failure to rest. So you're training too hard, running long distances, especially if you are into ballet and a dancer and have poor nutrition, so decreased caloric intake, low vitamin D, or some kind of nutrient absorption issue. You'll see this with the female athletic triad, an eating disorder or absorption issue, amenorrhea, and osteoporosis. Prevalent in female runners and ballet dancers who believe low body fat provides a competitive advantage. There are some dance troupes where literally, if your body fat is too high, you are not on the dance team. Medication usage potentially, especially with chronic steroid use, can be there. Smaller calf size and less muscle mass. Yes, your muscles absorb some of that force. So if you have less muscle mass, it means more is absorbed into the bone itself. Poor muscular endurance as the muscles start to fatigue sooner because of your lack of training. This may also increase the load over top of the bones. And then smaller skeleton size. Well, women in general have smaller skeleton size and increase height potentially because of longer lever arms generating more forces. Factors that influence bone mineral density include osteoarthritis, rheumatoid arthritis, osteoporosis, estrogen and testosterone levels can be low, and lack of weight-bearing exercise early in life. I cannot stress it enough how important, pun intended, how important early in life weight-bearing exercises are, especially in your teen years, to make sure you're laying down a good foundation of bone density. So assessment for this stress fracture, what are we looking at? Gradual onset of dull shin pain. Oh, it's got to be shin splints. Do not call it shin splints, and make sure you have the correct diagnosis, because whether it's shin splints, compartment syndrome, tibial stress reaction, or some kind of muscle strain, your treatments are very different based on those. All right. What else do we see? Majority of stress fractures occur at the junction or middle third, basically, is where it's most common. Often a recent history of increased training intensity or change in type or running on a new surface or new shoes, something like this, okay? Initially, the pain isn't there at the very start, but as the activity continues, or especially near the end of the activity, it may be worse, or with repetitive cycles of that activity as well. Physical exam, there is no major physical exam finding other than there is just sensitivity and specificity. Well, there's nothing specific for it, that will have sensitivity over the anterior shin, okay? History and exam are the key way that we diagnose this. So inspection, usually within normal limits. Rarely you might see some redness, especially if they've been rubbing the area or something like that, but you typically will not see swelling. Focal bony tenderness at the fracture site. And it's not a light push. You have to push in a little bit harder, check the unaffected side first, and then come back to the affected side. Usually motion is going to be within normal limits unless it's a more severe case, and neurovascular screens are typically going to be normal as well. Differential diagnosis, shin splints, medial stress syndrome is going to be better. Palpation focused on the tibia, more diffuse than shin, yeah, exactly. Exertional compartment syndrome, this is the one where the person runs a certain amount of distance and all of a sudden the leg feels full. I get foot drop, I get numbness between my big toe and second toe. It goes away as soon as I rest for 15 minutes. If it doesn't go away, it may be an acute compartment syndrome, and that is a medical emergency. Muscle strain that you're looking at here could be something as simple as DOMS. So that'll be on for 24 to 48 hours typically and slowly go away. Other things, rarely neoplasm and peroneal nerve injury, potentially. Usually look for some kind of impact trauma around the neck of the fibula. As we know, the common peroneal nerve runs around right there, but lower on my list. Although I have seen it before. I had one What was he doing? Dirt biker out in the forest there. And he was on the trails, and basically the side of his fibula hit a branch that was sticking out, and it resulted in a semi-permanent peroneal nerve palsy. That kind of was one that was obvious to figure out, but it's on your differential list. All right, special test. Any test that loads or puts tension on the tibia, and your fracture screen is key. So over the age of 55, history of significant trauma, repetitive training, all of that's going to be there, right? Inability to adapt or have time for the body to adapt because they're increasing their load too much. One thing that I'll even do potentially on my fracture screen for these patients is I will take their tibia and try and flex it. If everything else is negative, I'll put your tibia on the end of the table and I'll push down on the distal end while the proximal end stays secured by your knee and the rest of your body, and see if that little flex in the bone causes pain. And yes, your bones do flex. As you get older, they have less flexibility in them, but it's a natural process for bones to have some bendability in them. So diagnostic imaging is going to be warranted if you are lost on this case or trying to rule out another pathology. So history and physical exam are the best ones to do. If you are lost, you might go ahead and consider the imaging. X-ray, low sensitivity for stress fractures. It has to be pretty advanced before you'll actually see it on an X-ray. Bone scan will have high sensitivity but low specificity. It'll tell you there is an increase in osteoblastic activity in the area, but it will not tell you what the cause actually is. But if you're correlating it with the symptoms that the person has, cancer's on your list for something to potentially rule out, but cancers in this location are pretty rare. MRI is the gold standard for bony injuries, where you can see the changes. 43% of runners who were followed 12 months demonstrated evidence of tibial stress fractures. Yeah, pretty common injury. And so here we can see one right here in the more proximal middle part of the tibia right there, but we can see the stress reaction inside of that bone. All right. The disadvantage is it may take you a long time to get in for that MRI unless you have a great healthcare resources available in your area. Stress fracture based on findings of scans. So this is grading from 1 to 4. 1 is the most mild, 4 is the most significant. X-ray, nothing really shows up until grade 3 or 4, especially if you see this periosteal reaction. You know that fracture, the body is actively trying to heal that. But again, you have to be fairly advanced. Bone scan, you can see grade 2 or 3, a sharp uptake and increased local signal intensity with a grade 4. But MRI shows you increased activity, T2, poor definition. And then if you go T1, T2, you can see the focal areas. All of this will show you increased edema in the bone potentially, or what we could classify as a bone bruise possibly. And then of course in grade 4, you will see the fracture screen on both T1 and T2. Management options: protect the area from future injury and overload is key. If you do not do this and continue at the same activity level and try and work your way through the pain, you can make this a full fracture. Now, this wasn't a tibial fracture, but I'll give you an example of one patient, Olympic bobsled team here in Canada. And she came in and she had of all things, a navicular fracture for whatever reason, or stress fracture, I should say. For whatever reason, she decided that her foot was going to pronate the way it did, and the net force for her was over top of her navicular. So regardless, she had a stress fracture. It was confirmed by exam and also confirmed we actually did a radionuclide bone scan, so you could see the increased uptake. Extremely rare location for cancer. She was pretty young, so not typically the case. Biggest, strongest legs I've seen in an athlete in a long time. But regardless, I gave her the choice. I said, hey, you can go ahead and rest for 4 to 6 weeks here, and then you can get back to your activity, or you can make it a full fracture. Guess what she chose? She chose full fracture and then was forced to take time off and switch to other cardiovascular maintaining exercises. So educate the people, empower your patients on this so they understand what happens if they don't change their activity. Most people are not Olympic athletes and psychopaths where they're going to work through that pain. Their body is telling them it hurts. They're going to listen to their body and modify their activity. So the goal here is you want it to be pain-free activity, especially in the earlier stages of healing. Later on, when they're working their way through, you can challenge that pain a little bit. But for the vast majority of people, start off nice and easy. Consider crutches with ambulation to start, non-weight bearing. Even an air cast is not a bad idea. These things might help the athlete cover a little bit more quickly because they decrease the load, but you can still move it around in light ways. Consider a soft orthotic or even just an insole in their shoes to reduce trauma potentially, and make sure they are getting the nutritional support they need for that healing as well. So vitamin C, D, magnesium, zinc, all that good stuff. And there is some research to support the use of microcurrent to potentially improve healing as well. All right, prevention and education, biopsychosocial support, educate the person on what's going on and what they need to do to help get better. Identifying predisposing factors like osteoporosis, or if there is I put menstrual issues here because of the female athletic triad. Look at that overtraining, leg length issues, foot mechanics, even sport-specific activities, pelvis and back movement ability that you might see with restrictions of movement or muscle imbalances, or other activities they're doing that could contribute to this imbalance. And then, of course, prognosis. Most will resolve without issues in 3 weeks, typically 4 weeks. More significant ones, you'll be on that higher end of the 9-week area right there. Surgical consultation is indicated in severe cases if you suspect there is a displaced fracture, in which case it's not, well, a stress fracture can become a displaced fracture, but not typically what we're going to be dealing with our conservative management pathways. All right. And then, of course, always watch out for that affected female athletes who exhibit signs of an eating disorder and amenorrhea and potentially overtraining, because you're looking at that female athletic triad. Literally, their body is under such stress, they're not menstruating anymore. It's their body's protection mechanism saying you cannot have a baby right now because your environment is too hard to develop a child in. Refer for counseling. Do not treat this type of patient alone. There are other people who can help with you to take on the load for that patient and get them the best possible outcomes. Don't be a hero. Always referring to other people who are experts in their fields, who can facilitate the best outcome for your patient. That is our entire goal for everything that we're doing. So remembering again, basic process. Number 1, tibial stress fracture. What happens? Increased training too fast or intensity too soon. You get anterior shin pain. It lasts for about 3 or 4 weeks potentially and doesn't go away. You have to modify your activities. Our best treatment options are number 1, education of the patient, empowerment to realize what this involves and the normal healing process of it. Looking at referrals when they are required, graded exercise exposure or activity modification, and lastly, our manual therapies to help support this entire process. All right, and that's a quick run through tibial stress fractures. I will thank you very much for your time and see you on the next video.